Thank, thank you, Rajalakshmi, and good afternoon, everybody. So here we have been talking about generally about the various symptoms and the communication ethics. But in the first session itself, we have made it clear that palliative care is not only applicable to cancer, but also for any patients with serious ill-related suffering. So we will be focusing more on non-cancer patients who require palliative care, and do they have equal or more or less suffering compared to cancer patients, and do we need to integrate palliative care principles into the non-cancer patients who requires who is suffering from various problems. So today's session will be taken by Dr. Sunitha Daniel. So Dr. Sunitha is a specialist palliative care physician presently working at General Hospital, Ernakulam, and she has done her MSc in medicine and palliative medicine, and she has been associated with us for various teaching programs. So welcome, Sunitha, and it's over to you.
Thank you, Sunil. Thank you, Rajlakshmi. Thank you, Pallium, for another opportunity. So the topic for today is palliative care for non-cancer illness. What I'm hoping to cover in this session is to understand why patients with non-malignant diseases would benefit from palliative care, and how do we go about identifying such patients. And I'll be briefly touching on a few of the diseases. It's not possible to cover all the non-palliative, non-cancer conditions in this session. So I'll be briefly touching on COPD, heart failure, dementia, other neurological conditions, end-stage kidney disease, major psychiatric illness, and frailty. I would like the session to be a bit interactive, so I've included a few multiple choice questions in between the session. So you just have to type your answer in the chat box as and when the questions come. So we'll first think about George, who's an 81-year-old. He's a retired teacher. He lives with his wife, Susan. He was diagnosed with dementia about 5 years ago, and he is deteriorating now. In his present condition, he's dependent for all aspects of care on his wife. He's doubly incontinent, and he has difficulty communicating. He's only able to walk about 2 to 3 steps. In the last 1 year, George has been seen by a general physician, neurologist, and cardiologist. And he had 3 admissions to hospital in the last 12 months for pneumonia. His last admission was about for 4 weeks. And after each episode, he did not recover back to the point where he was before. And on the last admission, he died on the ventilator. So keep George in your mind while we go to the presentation. We'll be touching on dementia in the end, but just have a think about George. So I'd like to pause here now and give you a chance to think about George. And what do you think, having covered about 8 sessions of palliative care, if a palliative care physician was involved in the care of George, what difference could we have made? Just, you can put your ideas in the chat box. Which all aspects of George's management would require a palliative care input? I'll just pause for 1 minute and wait for some answers to come in the chat box. So anything of George's care can be improved by a palliative care team. What do you think could have been done differently?
I can't see any answers.
Okay.
But if anybody want to talk, please talk. If you don't.
Okay, I've got one from Shilpa which says multiple. Yeah, good. Ventilator, home care, very good. Avoid hospital admissions. He could have died peacefully at home. Okay. So I think you do have a general idea. So what I was trying to say is how we could have improved his symptoms, maybe his quality of life in the last 1 year, better end of life care, and also for Susan, maybe a bit of bereavement care also. So you must be familiar with this definition of the World Health Organization, which defined palliative care in 2001, but the focus is on patients with the life-threatening illness and how we aim to relieve their suffering. So we look after their problems, which are physical, psychosocial, and spiritual. And I hope you're also familiar with this current definition, where in 2018, the International Association of Hospice and Palliative Care have redefined palliative care as a specialty which now cater to patients and caregivers with a serious health-related suffering. Now, this definition has been accepted by consensus by the palliative care physicians all over the world. And they've also provided us with a list of conditions, about more than 20 conditions are in this category, which are thought to be causing serious health-related suffering for the patients, and where there's a benefit of palliative care input. And you can see there's a long list of non-cancer conditions in that. This map shows a predicted increase in the serious health-related suffering from 2016 to 2060. So what it shows here that, as you can see, the darker areas are the low income and the low and middle income countries. So what we can see is that there's a predicted increase of about 155% of serious health-related suffering by 2060 in low-income countries, and around 87% of increase in the suffering for patients who are from the low and middle-income countries. So the cases are definitely going to increase for us. Now, this is a chart which gives us the predicted number of deaths due to various conditions and how it's expected to shift. Now, you can see that the malignant conditions tops the list, but in addition to that, it's expected that the number of deaths due to cardiovascular accidents, lung disease, and dementia will also rise by 2060. Now, this graph shows how the major cause of death has changed worldwide over the past 20 years. The deaths due to communicable disease are indicated by the red area of the graph, which is gradually coming down, as you can see. And the predominant ones are the non-communicable disease, which is shown in blue. And that graph, or that shade of the graph, is increasing. Now, this is a similar case in India also. India, we do have our own share of communicable diseases, which is still high, but there's an increasing trend of NCDs and non-communicable diseases even in our country, and deaths are also increasing because of that. So like many other developing countries, India is also having an increased surge of non-communicable disease, which are mainly because of related to the lifestyle changes. So unhealthy eating, excess alcohol, physical inactivity, and tobacco use will all contribute to the increasing number of NCDs, and including cancer, cardiovascular diseases, chronic respiratory disease, and diabetes. But the major challenge in our country is that most NCDs are now occurring at a younger age group than in developed countries. So that's a major socioeconomic impact on the country, because it will be challenged to implement appropriate prevention strategies to actually decrease the growth in trend of these NCDs. And also because the patients tend to be having these NCDs for a long period of time, we need to provide care for them over a longer period of time. And that is on top of the seasonal communicable disease that we still continue to face. The data from ICMR in 2017 said that the state level disease burden of non-communicable disease is about 40 to 75%. And the highest number, according to this document, is from Kerala, Goa, and Tamil Nadu. The lowest number is from states of Bihar, Jharkhand, Uttar Pradesh, and Rajasthan. Now, coming to how effectively is palliative care or palliative care specialty now being involved in non-communicable disease management. Now, this retrospective cohort study was done in UK, which is supposed to be the country where the palliative care is most developed, on the community and hospital care palliative provision in a large UK city. It's published in 2016. So out of the 4,000 patients which were included in this analysis, what they found that only about 700 patients had a non-cancer diagnosis. So the patients who were referred to palliative care, out of the nearly 4,000 patients, only 700 had a non-cancer diagnosis. And the median duration of palliative care before death was only 16 days. That means these patients were only seen about 16 days from the death. So this shows that even when the settings where the palliative care is well developed, non-cancer patients are not referred enough. What the research suggests is that optimal at least 6 months before death, they should be referred to palliative care. So the first question or first quiz is, it's a multiple choice. So what is the most common symptom cluster of advanced cancer, as well as AIDS, heart disease, COPD, and renal disease? So cancer and non-cancer condition, which is the most common symptom cluster? Is it A, pain, breathlessness, or fatigue? B, pain, vomiting, and constipation? C, breathlessness, delirium, and constipation? Or D, depression, anxiety, and anorexia? You can answer anything that comes to your mind now. Any answers yet, Sunil?
Yes, pain, breathlessness, fatigue.
Oh, good. Okay, thank you. So it's pain, breathlessness, fatigue is the most common symptom cluster. And this was reported in a paper by Solana et al. In JPSM. The three symptoms of pain, breathlessness, and fatigue were found among more than 50% patients in all the 5 diseases. So they compared. So this is the full list of symptoms. So you can see that cancer patients, the common symptoms are dyspnea, pain, fatigue, depression, anxiety, and anorexia. You can see the percentage of those symptoms in each of the non-cancer conditions. So if it's COPD patient, they probably will have dyspnea more than a cancer patient. Heart failure, again, fatigue is very common. CKD, anxiety is common. But do these patients get referred to palliative care? How are their symptoms being managed? Because nobody knows that you can refer them to palliative care. So all these patients are dying without the symptoms being managed. So now we come to conditions one by one. Now, another study published as early as 2000 in Thorax, it compared the quality of life in end-stage COPD and lung cancer, which showed that patients with COPD had poor quality of life, as well as more breathlessness compared to those with lung cancer. But none of these COPD patients received any specialist palliative care services because nobody knew that you could refer them to a specialist palliative care service. So those who had COPD along with cancer probably would get a referral because of the cancer diagnosis, but the COPD patients didn't get any referral. Now, and the prospective cohort study of seriously ill patients or hospitalized patients with COPD and lung cancer. Now, equal number of patients in both the groups wanted to have supportive care and did not want ventilation. But once they followed the patients up, they found that more patients with COPD ended up receiving ventilation, but cancer patients obviously didn't receive ventilation. So even when the patients didn't want to be ventilated, in practice, at the stage when they were ending up having a ventilation, because the advanced directives was not done, all these patients with COPD ended up having or being put in the ventilator. So that's importance of doing advanced care planning for patients who are in end-stage conditions, irrespective of the cancer or non-cancer status. Now, so how do we get involved, or what stage do we get involved in advanced COPD? So this is how the pharmacological therapies of COPD patients goes in step by step. So you can see that initially when they have a diagnosis of COPD, obviously you start them on short-acting bronchodilators, long-acting anticholinergics, long-acting beta-2 agonist. And all these are put on, and still the disease will progress, so the symptoms will get worsen. So what happens is that once the magnitude of dyspnea or shortness of breath increases, they are on regular follow-up. They come up at a point when you can actually start them on non-pharmacological therapies for breathlessness management. I hope that has been covered in the session on breathlessness. So exercise, breathing exercises, walking aids, neuromuscular stimulation, chest wall vibration. And the next stage is, even when after given the non-pharmacological therapies, the breathlessness is not getting any better, you can put them on a short and long-acting opioid. Low dose of morphine can be given. The maximum that is a trial is up to 30 milligrams. So you start with 2.5 milligram of morphine as and when needed. You can put them on a long-acting and short-acting morphine, and you maintain them of 30 milligram, and it's shown to work for chronic breathlessness syndrome or breathlessness not responding to the conventional treatment. So the thing to remember is that all these patients are on the maximal optimal treatment for their disease condition, which is COPD here, and still they are breathless. So morphine is shown to be beneficial for such patients. Now coming to heart failure, and that will bring us to the next question. What percentage of patients diagnosed with a heart failure die within 5 years of first hospital admission? This is from a UK data. So percentage of patients who had the heart failure diagnosis and they had a first hospital admission. So what percentage of patients will die within the 5 years of the first hospital admission? Okay, I've got lots of answers coming. So the answer is C, that's 50%. It's 50%, C. So what you've seen is that in UK, the incidence of heart failure is about 1 per 1,000 population per year. Now the survival rates are worse than breast and prostate cancer in UK, but you don't realize that. People live with a heart failure or are diagnosed for a long time and thinking on normal medications, but you don't realize that they've got a poor survival rate as compared to breast or prostate cancer. And half the patients who are diagnosed with heart failure actually die within 5 years of their first hospital admission. Hospital admissions usually because of when you can't manage the symptoms of heart failure in community and you need IV diuretics, they end up coming to hospital. And the study has shown that they die within, half the patients die within 5 years of the first hospital admission. So, and also there's a potential for sudden death in heart failure patients. So that's why there's importance of doing an advanced care planning earlier on in the stage of diagnosis. Now, you can classify heart failure. There's New York Heart Association NYHA classification, and there's American College of Cardiology or ACC classification. Now, NYHA, I think we're all familiar with that. You classify them to class 1, 2, 3, and 4. And ACC classification stage A, stage B, stage C, stage D. So in class 1, there's no limitation of physical activity, which is equivalent to a stage B in the ACC classification. Heart disease is present, but there are no symptoms. So usually when palliative care gets involved is class 3 and class 4 NYHA classification. So there's marked limitation in physical activity, and they're unable to carry out any physical activity without discomfort. When there's a presence of advanced disease with continued heart failure symptoms requiring aggressive medical therapy. I have a slide with all the medications you can try for heart failure. And this is how they normally start these medications depending on various classes. So you can see they go for diuretics first when you're in NYHA class 2, and then they progress on to ACE inhibitors and beta blockers. The reason why I'm showing this slide is that we tend to stop lots of medications for patients when they come to a palliative care team, because we try to rationalize medication. But some tablets, especially for heart failure medication, should be continued at least till end of life, because it helps with the symptoms also. So it's shown to improve the survival and also improve the functional status. So we should be careful which are medications. Obviously, if the patients can't tolerate the medicines due to various reasons, including low blood pressure and all, then we are justified in stopping them. But otherwise, these medications have a role in symptom management also. So these are the medications that is tried for heart failure. Coming to end-stage kidney disease, and that will bring us to the third question. Patients who benefit from palliative care and end-stage kidney disease are A, those who choose or advise not to start on dialysis, or they are going to conservative or non-dialytic management. B, those who are failing to thrive on dialysis and who experience worsening quality of life and increasing symptom burden. C, those who discontinue dialysis, and or D, all of the above. Yeah, it's D, it's all of the above.
Yeah.
So these are the indications for end-stage kidney diseases. These are patients who, so there'll be two groups of patients. So once there is end stage and the nephrologist will tell them it's time to start dialysis, the patients can either choose not to go in the dialysis route, or they probably have financial issues and can't afford dialysis. But they should be referred to palliative care team because they have lots of symptoms that needs to be managed. Now, people who are failing to thrive on dialysis, who experience a worsening quality of life, and in spite of dialysis, they still have symptom burden. And obviously, the patients who are on long-term dialysis, if you stop that continuously, stop that suddenly due to any reason, they actually can die pretty quickly. So the average survival for patients who come off dialysis is actually 8 days only. That means they're on long-term dialysis and we stop that. So average survival is found to be 8 days. So they definitely need referral to palliative care team. So these are the indications in end-stage kidney disease. And we know that end-stage kidney disease also have got an extremely poor quality of life. Most of the time they spend in the 3 days a week, they have to go for dialysis usually. They also need frequent hospitalizations, and the prognosis actually comparable to common malignancies. And as I mentioned before, there are symptoms also which can be elevated, so dyspnea, confusion, pain, anxiety, depression are very common especially during the last few days of life. Now, this is another study that was done in UK. This was a landmark study, actually. They collected, this is a retrospective observational study published in 2013, where they compared the survival and the palliative care involvement of two groups of patients who are over 70 years. As I mentioned before, there were a group of patients in this particular hospital in UK who chose not to go for dialysis and to go for conservative management. And those patients who went for conservative management were seen, they were still being followed up by the nephrologist, but they were jointly seen by the palliative care physician. And they received all the supportive services, including dietitian support and physiotherapy input, and all those were given, except dialysis. And this one group of patients just went for dialysis. And this retrospective study was done to compare the survival and the quality of life. And what they found was that the study was done over 70 years, but in the group of patients who were more than 80 years of age with a poor performance status and they had high comorbidity score, actually when those who chose a non-dialysis route survived longer than those people who chose the dialysis route. So it was a landmark study. It was like an eye-opener. So patients who go for non-dialysis or conservative route who are 80 years or more actually did better. They survived better than going the dialysis route. And as expected, they have better quality of life because they had palliative care support also. So this actually went, helped them to start lots of palliative care joint clinics in the UK, which is based on this study. So conservative management pathway had greater access to palliative care, and they were less likely to be admitted or die in the hospital. Coming to dementia and other neurological conditions. So next question. Which among the following is the most common symptom in advanced dementia? Is it confusion, urinary incontinence, pain, or low mood? I think this is very straightforward.
Confusion.
Confusion. Okay, good. So confusion is the most common. These are the symptoms of advanced dementia. You can have confusion. About 83% of patients can have confusion. Then episodes of urinary incontinence, pain, low mood, constipation, and loss of appetite. So confusion is the most common symptom in advancing dementia. Now, how do you monitor these patients with dementia? There are various scales are available for staging. This one scale called clinical dementia rating, or a CDR scale. We've got global deterioration scale, or GDS scale. And the one that I've mentioned in the screen is called FAST, or Functional Assessment Stage Scale, or FAST scale. Now, it describes the different stages of dementia. It's a 7-stage system. And it actually, rather than the mini mental state, state examination, MMSC, which goes into the cognitive and the memory impairment, this is to deal with the functional aspect. So what all can they do? So it actually tells the different stages of dementia. And now, for FAST scale 1 is like a normal adult. There's no subjective objective difficulties. When you come to 2, it's like a normal older adult. So it will be misplacing objects, subjective word finding difficulties. 3 is like early dementia. So they have got difficulties job performance, or with evident to co-workers, difficulty in organization. 4 is mild dementia, impairments of instruments of ADLs, all the ADLs are impaired. 5 is moderate dementia, needs assistance with dressing to match weather or the occasion. So they're unable to choose the right clothes for the right occasion. Now 6 has got, it's divided into A to E, and 7 is also divided into A to F. 6 is a moderately severe dementia, and 7 is a severe dementia. So 6, there'll be difficulty of bathing, dressing, toileting. There'll be occasional urinary incontinence or fecal incontinence. 7, it goes into a severe dementia where the speech is affected. So they can only speak about less than 6 words a day, and they can't ambulate properly. They can't sit up without assistance. Smiling is lost, and finally, they can't even hold their head up. So that is how you grade the severity of dementia. And that's how you assess when the palliative care, input is needed. So when you think about George, so as you mentioned, what all interventions can you give for George? Symptom control, advanced care planning, avoidance of potentially burdensome treatment. So if you have an advanced care planning for George, we could have told that if he's got a mild chest infection, probably we'll keep him at home, give him some oral antibiotics, but won't take him to the hospital. The problem with admitting patients who have got dementia to hospitals, actually, you don't do them any good, but mainly because they become more confused when they're in an unfamiliar situation. So they become agitated, they become scared. So what happens is you tend to sedate them in hospital, which again actually worsens their solo and worsens the chance of aspiration. So always it's better to keep them comfortable in a familiar situation. So all these can be achieved only through advanced care planning, avoidance of potentially burdensome treatment, and hospice if there is a palliative care team. If they want to be admitted to some inpatient unit, why not go to a hospice where it's much more quieter? It's not like a busy hospital unit, and you can familiarize surroundings. So hospice rather than a hospital, admission, and also give support to caregivers. So Susan, who's looking after George, will need lots of support to accept the fact that he's deteriorating. It's a progressive disease. So that's all important. If you could have got the referral of George earlier on to do all these things. Okay. Now, some other conditions other than dementia, which probably in situations where this is a common, palliative care does get involved. One is motor neuron disease or amyotrophic lateral sclerosis. And there's a need for a lot of input for, especially, you can have advanced care planning to go into, is a patient going to have a PEG feeding or not? Is the patient going to have a non-invasive ventilator or not? Is she going to be ventilated? All these things can be discussed in advance. Parkinson's syndromes, you can have symptoms at the end of life. So how do you manage them? Multiple sclerosis and ischemic and hemorrhagic stroke also, you get referral in palliative care. Now, a few symptoms that can happen in neurodegenerative conditions and what you do for that. So constipation is common in most of these. So it's managed and is similar to the other how do you manage constipation? You'd have learned about that. So sufficient hydration and laxatives, different types. Dyspnea, you can try opioids. So all these are management for palliative based end stage management, not the first line treatment. Anxiety, you can try anxiolytics like benzodiazepines. Fatigue, psychostimulants can be tried. Muscle cramps, you can give quinine. Pain, again, depending on severity, you can try non-opioids and then go to opioid if needed, or even neuropathic agents if pain is because of neuropathic pain. Pseudobulbar effect, like it's a nervous system disorder where patients can become laugh or cry or become angry in between. They don't have a control over it. So it's called emotional dysregulation. Quinine is seen to work for that. Other things like pseudo hypersalivation, so you can give amitriptyline for that to dry up. Hyoscine, botulinum can be given. Patient can become psychotic, agitation. Qutipin can be tried for that, or clozapine. Sleep disorders, respiratory failure, I mentioned was for motor neuron disease, you can go into respiratory failure. So you have to discuss things like tracheostomy or NIV as if needed, as appropriate. And also Parkinson's symptoms, how do you manage it end stage? So if the patient can't swallow, if patches are available, you could try rotigotine patch, or even you can give apomorphine as subcut infusion. Sometimes we don't have any of these medications and the patient is dying, but it's very, very rigid. You put them on midazolam and you might have to give them high dose midazolam to actually help with this rigidity. So that's also can be given a subcut infusion. Sleeplessness, again, night sedation, amitriptyline can be tried, mirtazapine can be tried, spasticity, baclofen, tizanidine. And when there are thick secretions, you have to go for mucolitis like amproxol or N-acetylcysteine, supportive measures like nebulized saline and cuffing techniques, postural drainage, all can be tried. Next, we come to frailty in old age. Now, what percentage of world's population is projected to be over 65 by 2050? Any guess?
%18%.
Okay, the answers are all very close together. So answer is 16%. So what they say is that by 2050, it's projected that about 16% of the world's population will be over 65. Where if you compare that with 1950, it was only 5%. So our old, because the healthcare system is improving, obviously we get a lot of old people. And frailty is a condition when we, not just any old people, but old people who have a diminished capacity to withstand any stress. So what happens is that they are very vulnerable to adverse outcomes. They'll have some sort of physical disability, and so they don't have dementia diagnosis, but they'll be basically diagnosed will be old age. So they'll have impairment in activities of daily living. They'll be socially withdrawn. The motor process will be very slow. They'll have some cognitive changes, weight loss, or negative energy balance. Why is it important to actually assess that? Because these patients there are increased risk of falling down. They can have hospitalization. and they can go into disability. And even death, 3 to 5% of deaths occur in older adults could be delayed if frailty was prevented. So the frailty, it's contributed by their primary comorbid illness. So like, how do you prevent that? So how do you address? So make sure that the hypertension is well controlled, make sure that the diabetes is well controlled, all the chronic disease has to be managed sufficiently. Make sure they have got enough exercise and nutrition. So we have seen that, sometimes patients or some people, when they become old, they tend to sort of be laid back and take rest all the time. And, because they think they're old and they've been looked after. The problem is that they tend to have muscle wasting, and that will add on to the insult. So they'll have falls because of that. So if possible, if they continue to be active, do light exercises, look after nutrition, and improve their function, improve function, control the symptoms. Psychological well-being is very important, and also prevent hospital admission. So always better to keep them at home if possible. Always when you see frail old people, once they go into hospital, I've always heard bystanders saying that they were okay when they went to hospital. After prolonged stay in the hospital, they come back, then they don't actually get back to their baseline. So it's always important to see whether you can manage things at home, have a good palliative care, and see whether some conditions at least can be managed at home. And the hospital admission should be the last resort in such patients. I will also mention about the major psychiatric illness. And the question in that is, what is the prevalence of major depression in oncology? So for cancer patients, what is the prevalence of major depression? Is it 10%, 38%, 60%, or 70%?
D is 70%.
It's not that common. 38% is the answer. It is common, but it's not that common. So prevalence in cancer patients, about 38% actually have got depression, major depression. And in the general community, the prevalence of depression spectral disorders is 58% compared with 6.6%. 12-month prevalence is 16.6 lifetime prevalence in the general community. So it's common in cancer patients. That's the thing that you need to know. And it's actually, how do you actually label them? It's a depressive disorder due to another medical condition. So it can be because of conditions like hypothyroidism, chronic uremia, cancer-induced cytokines itself is actually thought to be causing the depression. It can be medication effects of steroids, etc. So DSM-5 category. Why is it important for us to understand about depression cancer patients? Because as we all know, untreated depression, it can affect the treatment adherence. So patients will have, one is reduced understanding about the cancer diagnosis. So they are not sure when they make a decision about going for a treatment, whether they should they do or should they not do. They wouldn't be motivated to go for treatment. So they wouldn't be motivated to look after them. They will be pessimistic about the outcome and benefit. And also there'll be poor tolerance of the side effects. And the problem with our community is that there's still a lot of stigma associated with the mental health, isn't it? So, people will say, okay, she's sad because she's got a cancer diagnosis, which is understandable. That's a normal reaction to a cancer diagnosis. So that is understandable. But there'll be a point when you might need medications. So there is a point when you have to pick up the fact that that is just not being sad, but the patient has got a clinical diagnosis of depression. And it's important to to identify that, and also to get the help on time, because it's important for treatment compliance. So then only they'll understand the need for taking treatment. So there are different tools that can be used for screening for depression. Again, you must have heard of all these tools. I think the common ones that has been used is NCCN, the National Comprehensive Cancer Network, has got a distress thermometer. So they actually suggest screening all the patients who comes to. So now I think most of the oncology centers will have a psychosocial or a psycho-oncology department. Along with that, they do distress screening, as well as they do some sort of screening to look for depression. And even if you don't do all these elaborate screening tools, you can at least ask a single question: are you depressed? Which also seems to be having some sort of a evidence-based in picking up the patients. How is your mood? Do you feel low in mood? Do you feel tearful all the time? Do you feel like taking your life? So all these questions can be asked, and it's important to know that, because it's a common condition in cancer patients. I've briefly mentioned some pharmacological treatment. Again, you must have covered all this in other sessions. So you know that tricyclists, for us in palliative care, and even the other one, we don't use it for depression now. It's mostly used for pain and neuropathic pain. You can use citalopram for depression, and venlafaxine, again used for neuropathic pain, but can be tried for severe depression. We tend to use some newer agents like mirtazapine, which has got a very few side effects again, but it seems to be working for depression as well as anxiety. It also has got appetite and weight gain, and also works for decreased sleep. So mirtazapine is like a favorite drug among palliative care doctors now, which is a single drug which can cover a lot of symptoms. So we tend to use that. Even the dosage given in this is 50 to 60. We usually go for 7.5 milligram in our patients, and we gradually increase that up if needed. And sometimes it works for neuropathic pain also, but there isn't any RCTs for that. But there are some case reports which shows that mirtazapine works for pain also. Others like trazodone can be used, and psychostimulants. So methylphenidate is one of the psychostimulants which works pretty quickly. So it's for those patients whom you think the prognosis is quite short. So they won't, the conventional antidepressants takes at least 6 weeks to start working. And some people, you look at them, you think that they're very, very low in mood, they've completely lost the will to live, and actually they don't have much prognosis. You're justified in trying a dose of methylphenidate, which is quicker acting, but it needs it actually needs a monitoring. So, especially blood pressure and all, it can put the blood pressure up. So, but we do try that in palliative care. A low dose of methylphenidate can be tried and titrated up, and depending on the response, and usually it should start working in 1 to 2 weeks. And sometimes it does seem to work within days also, but if it's not beneficial, you stop it. So psychostimulants are tried for people who have got very short prognosis. So we quickly covered, I know it was very, very fast, the few of the conditions. So what do you think are the barriers? Why are these non-cancer patients not getting the palliative care they need? What do you think are the barriers? So I think you must be familiar with this graph. These are the 3 graphs for the typical trajectory of the patients. The one on the top is a cancer patient. So what we see is that cancer patients, they have, they go on with this with the treatments. That's a straight line. And once they reach a point of metastatic stage and the treatments don't work, they have this sudden dip when they become very unwell, become more sleepy, and that they are dying. So it's a bit more clearer in cancer patients when we know that when should we go for palliative care. That dip is very, very clear, at least clearer. But the second graph is a non-cancer patient that we have seen all these. So what you see is that they come to you've got a diagnosis of heart failure, you get worsening symptoms, you get refractory heart failure, you go to hospital, you have a dip, but then you get some treatment, then you come back. So you don't come back to the baseline, but you are better. So you go again for some more time, and then you get under dip, and again you come back up. So you recover from that, but you are not back to the baseline, and then you go down again. So at what point does the doctors decide that actually this is a terminal event? It's difficult to say. It's not easy for everybody. It's not easy for palliative care doctors or any other doctors. So that is a major barrier in actually identifying when do we say these patients are actually end of life, or they can benefit from palliative care. So that is a major barrier in identifying. And this last one is a frailty and dementia patients, where there's a prolonged dwindling of the condition. They're mostly frail, and then they sort of reach end of life. That's the dementia patients. So this is one of the reasons why there is a barrier. Now, the other things from the doctor's point of view, what happens is that, as we said, not knowing how long the patient will live, it creates an uncertainty. We don't know whether it's the right time to choose palliative care or not. The second one is the using the word palliative care. The patients feel that, or doctors feel that the patients will be alarmed, the bystanders will be alarmed. Will they think they're going to die immediately? So that could be one of the reasons. And again, we all think that doctor's job is to save life. So if you think that death is a failure, then you won't be able to accept palliative care. You could have, you might not have the skills for symptom control. You might not have enough special palliative care resources, or the hospital policy could be the reason, especially private hospitals may not be quite open to palliative care. All these could be the reasons or the barriers. What are the barriers on the side of patients and family? So patients and cancer carers would be thinking that I don't have cancer, so why should I see a palliative care doctor? Because still everybody doesn't know that palliative care is for non-cancer conditions also. Sometimes if there's a failure to recognize it as a terminal illness or poor preparation, and caregivers are unprepared to decide whether you have to go from the life-sustaining treatment to the aggressive comfort care. It's difficult for the family to decide. Now, there are some tools that's developed. This is mainly for the doctors. So you've got the supportive and palliative care indicator tool or SPIC tool. It's a guide to identify the people at risk of deteriorating health and dying. So the tool, if you could find it in the internet, is a very good tool. And it has got different indications for different conditions. So the major one, the broader one, what we say is that look to there's some general indicators. So 2 or more general indicators of deteriorating health, like the performance status is poor or it's deteriorating. Patients depend on others for the care needs. 2 or more unplanned hospital admissions in the past 6 months. So George had about 3 admissions, isn't it? So the last 6 months, 2 or more admissions. Significant weight loss over the past 3 to 6 months, and low body mass index. Persistent symptoms despite optimal treatment of the underlying condition, and the patient is asking for a supportive palliative care. Patients asking for withdrawal. So these are the 2 or more general indicators of deteriorating health. And then specifically for each condition, the SPIC tool gives you some indicators. So some specific indicators, as I mentioned, is for heart, it's NYHA class 3 or class 4 heart failure, extensive coronary artery disease, symptoms of breathlessness, chest pain, or severe inoperable peripheral vascular disease or PVOD, gangrene and all, it's inoperable. Then, it's better to involve the palliative care team. Liver disease, we didn't cover liver disease in this topic, but advanced cirrhosis, diuretic resistant ascites or hepatic encephalopathy, hepatitis. It could be the first episode, but I think it's best to call in the palliative care team at that point, or refer the patient. Kidney disease, we covered that, stopping dialysis or advanced diabetes unresponse treatment. And it also has got, if you can refer SPIC document, it tells you about the neurological conditions also and cancer. So access to the palliative care should be based on the need rather than diagnosis. So any patient, any diagnosis, but if the need is there, then you should refer them to palliative care. Now, there is something called a surprise question. So a single surprise question is recommended to offer palliative care to anybody. So the surprise question is, would I be surprised if the patient died in the next 12 months? So if you see a patient in home care, in your OPD, and you ask yourself this question, will I be surprised if this patient dies in the next 12 months? And if I'm not surprised, or if I think that the patient is going to die in the next 12 months, then maybe it's a time to call the palliative care team in. So that is a single, like a good question that you can ask yourself when you see a patient, and it's your clinical judgment. Listen, you'll be able to answer that question really well. And then if you think that the patient is not going to die, if you think that patient is definitely going to die within the 12 months, and that's not going to surprise you, then maybe you should call the palliative care team in. So just to conclude, the palliative care is needed for patients with serious health-related suffering, which can include both cancer and non-cancer. And there is a need for further research into the needs assessment tool for specific conditions, and as well as for the evidence of the benefit of palliative care involvement. Thank you very much for listening.
Thank you, Sunitha. So anybody has anything to ask regarding this? Any question? How the survival and quality improved without dialysis in CKD? That is one question.
So I'll share that paper with you. I'll send it to Rajalakshmi. You can have a look through that. So this is mainly for patients who are 80 plus, right? And the thing to remember is that they had input for the palliative care team, so they had supportive service also. And obviously, the team is much more developed in UK. So you got dietitian input. They managed the symptoms. They had advanced care planning. You know, all the metabolic abnormalities was corrected. All those was looked after. Only dialysis was not done. And possibly those patients probably had output also. It's not like they're going to end stage, like pulmonary edema or anything like that. So maybe that's one of the reason. But definitely, I'll send you the copy of that paper, and you can actually go through that in detail and find out. So it's for 80 plus patients. So the problem with 80 plus patients who goes on dialysis is that they have to visit the hospital every 3 days. They can have secondary infections because of that. They can have electrolyte abnormalities which can end up in hospital. All those things must have contributed to them dying earlier than the patients who didn't have dialysis. So as I said, I'll share the paper with you. Yeah, so Shilpa has mentioned all iatrogenic problems could be prevented. Maybe that's the reason. And as such patients treated in my center, no, we are not. So I think in India, KMC, I understand, have started a renal supportive care. One of the postgraduate doctors, I think he was the first postgraduate palliative care doctor who qualified from Tata, maybe, Dr. Pankaj Singhai, along with Dr. Naveen Salins, have started a renal supportive care team. So that is a very good initiative from India. I work in Kochi. We don't have such centers here. It's very difficult to penetrate into non-cancer patients, even in Kerala, where palliative care is supposed to be very developed. Unfortunately, I don't have much success with non-cancer specialties here. Yeah.
You have more records of the London and European standards. What about the Indian standards of the diseases? Like, very few recordings you have about the Indian standard.
Indian standard in the sense?
The recordings
data.
of data of
that's the problem. All the published papers are from the European. So as I said, this renal palliative care is just starting in Manipal. So we need to have papers published. All the published papers, if you look in literature for the published papers, most of them are from the Western. Here. So we need to get more published papers from Indian.
Sunitha, we are going to publish a supplement on renal palliative care in Indian Journal of Palliative Care, a series of articles. So
okay.
It will be coming shortly. I'm also one of the authors.
Okay, from Pallium India.
No, not from Pallium India. KMC, there was a master class on renal palliative care at Sarva Medical College. KMC,
oh yes.
And,
yes. Okay.
After that, so a series of articles is going to come on renal palliative care, which will be Indian authors by Indian authors.
And also my presentation, the most of the content is actually from the Oxford textbook of palliative medicine, which obviously will be having only data from abroad. So that's the reason I wanted to make a presentation which covers the theoretical aspects from the Oxford textbook. But published papers, if you get from India, I'll definitely include in my next, when I actually update the presentation.
I just have a case. Can I?
Yeah, please.
Can I ask about a case actually? Hello?
Can she?
Yeah.
Actually, I have a person who is around 90 years old. She's on Mirta 7.5 milligram twice a day. And
do you know why she's taking that for?
She has that, she becomes very aggressive, and she was shown to a psychiatrist. Actually, she's my mother-in-law. And she was taken to psychiatrist, and he suggested Mirtas because she was sometimes, very emotional. Although she's a mild diabetic and hypertensive, all that. So Mirtas, but now she is like, in spite of taking Mirtas, she hardly sleeps for 1 or 2 hours. And she goes on scratching and scratching. She's got scleroderma also. So she scratches her dry skin because of the age. And she is always hungry, wanting to eat. How do we manage this problem?
Uh,
Any suggestion you can give me?
do you know what diagnosis a psychiatrist gave her?
He didn't write a diagnosis. Actually, we being doctors, the psychiatrist was working with us. He's our colleague. So he didn't write any this thing. He just suggested Mirtas and we started giving.
Okay. So I think I'll just, to my knowledge,
she has mild dementia. She had dementia because of.
So I think probably she has got, I could be wrong. What I'm thinking is, she has got this behavioral changes because of dementia. And, so normally if it's Alzheimer's, normally what they try is they try memantine, right? Sunil, they try.
No, she's not Alzheimer's.
They haven't diagnosed her. Yeah. Okay.
No,
so
she's
dementia,
not Alzheimer's.
No. So dementia also, you could have this in between, you could have this behavioral and psychological symptoms, BPSD is called, of dementia, which comes in for lasts for 6 weeks and she gets better. And then, comes back to baseline. And there could be different reasons for that, including, one could be UTI, it could be the fact that she's cold, she's hungry. You can't understand, she can't communicate the exact reason for that. For those cases, sometimes they try things like risperidone for a short time, and then you stop it. Now, to my knowledge, we use mirtazapine for depression. So if it's for like aggressive behavior and psychosis, normally we don't use mirtazapine. At least I haven't used, I don't have much experience in psychiatry. We use things like quetiapine and all for sleep and, psychosis and all. So I'm not very sure why she was put on mirtazapine. Sunil, would you like to add something to that?
Actually, it's an antidepressant, but I don't know why. Maybe is it because of depression?
Sorry?
Does she have the depression?
Did they think she had depression?
Yeah, she has depression too, because she's sometimes aggressive and sometimes, but she's very alert. Mentally, she's very alert.
Okay.
But she has depression. She doesn't talk sometimes. She does sometimes she's happy in her mood is she's depressed actually.
So it's like bipolar. It's bipolar disorder, isn't it? So she has ups and downs.
Ups and downs.
Yeah.
But not totally a bipolar.
Yeah. Okay.
So can we add something like for this?
Maybe we should, but I don't
other
know
than
what to
Mirtas.
Sunil, do you have anything to suggest?
If she is aggressive, I think quetiapine will be better.
Which one?
Or you could give quetiapine.
Quetiapine. Okay. Okay.
Yeah, maybe a small dose, 12.5 milligram.
Yeah.
Along with Mirtas, we can give?
I think, yeah.
I
think so.
It can be. There is no contraindication.
How much dose will be?
How much old is she?
How old is she?
She's 90.
Oh, definitely. Don't go beyond 12.5 as a starting dose. Even some people might suggest you to start with the 6.25 milligram.
6 point. Okay. Okay. Thank you so much. Thank you so much.
Okay, Dr. Sumit, thank you, ma'am. Dr. Sumit has asked a question about how to deal with incontinence and dementia, elderly dementia without scan and urodynamics, peripheral settings. So are you looking for medications or?
Yes, madam. Medication as well as working with mere clinical history.
Okay. Yeah, I don't think we start anything. We do any test for. I mean, if it's really, what we normally do is, I normally in practice will give only like if they are willing to be catheterized, we just manage it rather than medications wise. I just catheterize them and talk to family. But you can give, the incontinent tablets that we normally give for patients like that for dementia also, I believe. Sunil, do you want to take that?
The problem with incontinence, catheter is one of the options, but the problem would be they are going to remove the catheter by themselves.
Hmm.
Yeah, and it can lead on to sometimes to urethral bleeding and complications. So, if possible, that can be done, or otherwise, uh, maybe some adult diapers can be used if the catheter is not possible. But I think the medications which usually used in paraplegic for reducing the leaking, like oxybutynin, that may not be a good option in dementia patients because them that will actually aggravate their behavior. So that may not be option. I think catheter and adult diapers and possibly correcting the constipation which may be there in patients with dementia.
Okay. Dr. Shilpa has asked, it's a good idea to have all chronic diseases patients meet maybe once in 6 months or telephonically for early benefit of palliative care. Yeah, I think it's a good idea. So if you have got, I don't know which all settings you're all working, but you don't have to refer them to palliative. You just have to sort of, think about them in the holistic approach. So all the chronic patients that you deal with, monitor them every 6 months. Think of all the things that we have discussed today, and see whether there is a chance, are they deteriorating, are they becoming frail, is there all the parameters are okay, or are they tending to be more unwell, or is disease progressing, and discuss with the family accordingly. So always, it's what I've seen in my practice is that family would want to know how the things are going to change so that they can prepare themselves. So like especially for cancer patients, if you tell the family that they've got this cancer, it's metastasized to these areas, and these are the symptoms that they can come, the family can anticipate that. So if it's in the liver, you can have liver pain, or you could even have abnormal liver functions that can worsen in the future, or lungs, you can have breathlessness. So similarly, in non-cancer patients also, if you can tell them at what stage, at least as far as this is a stage of the disease, how things can change, they can, there's a chance that they can be admitted. Do you want them to go to hospital, or do you want them to manage at home? If they go to hospital in dementia patients specifically, they are in an unfamiliar situation, the condition might become worse. So do you want them to keep comfortable? So every 6 months, if you can review patients, at least telephonically, I think that might help in their in the future care. So I think that's a good idea.
Okay. Thank you, Sunitha. So what we have to understand is most of the palliative care units in India specifically focused on cancer palliative care, and I know a few of the palliative care centers see all the types of patients who require palliative care. So we have to expand our horizon to meet the needs of the patient with the serious health-related suffering. So we know that the symptoms which is suffered by non-cancer patients are equal, or in some patients it may be even more than palliative care, cancer palliative care patients. So it is important to understand that concept, and also make the community aware of the situations like the non-cancer patients requiring palliative care. And then only the referral to palliative care for patients with non-cancer palliative care will increase. And as per World Health Organization, the group of patients which require palliative care are mainly cardiovascular patients. And then only second place is cancer. So if you look at the statistics, any of the palliative care organizations in India, I don't think any organization, palliative care organization, will have this type of statistics. So we have to concentrate more on that, and as we know, we have to produce more data and articles, research, etc. needs to be come into space. And the life expectancy is one of the difficult things to predict in patients with non-cancer palliative care. So Sunitha showed you some of the trajectories which can help, and another tool which is used picked, and the other one is gold standard framework. And the easy question is what Sunitha has told you about will I be surprised if this patient dies in the next 12 months. And then if the answer to that question is no, then there are some general indicators that you can look for if this patient is having these indicators. And after that, then there are specific indicators for each diseases. Those are some indicators by which we can make them understand that this patient is going to be benefited by palliative care and aggressive interventions may not benefit. So thank you. I think we can move on to the patient story, which will be presented by Dr. Deepam.
Dr. Deepam, you can start.
Yeah. A very good afternoon to everyone. I'm Dr. Deepam Sharma. I'm basically MD Medicine. I did my fellowship in critical care. I'm based in Guwahati. I'm currently associated with the Apollo Hospital here. Yeah. My case is regarding palliative care in a non-cancer setting. So we have a 65-year-old female whom the primary diagnosis was LVF, which was primarily a heart failure with preserved ejection fraction. That is the diastolic heart failure we previously called. And she also had a recent COVID-19 infection. And now she presented with a lower respiratory infection, and she is known CKD patient. Next slide, please. So the presenting complaints were she had a fever and a cough for 3 days, and she had the difficulty of breathing for 1 day, for which she was brought to the hospital. Next slide, please. So in the history of illnesses, she is a known CKD patient who was undergoing routine hemodialysis for past several years. And she has a recent hospitalization for COVID-19 for quite a long 3 weeks, and she was discharged around 20 days back. But however, she was unwell for last 6 months, and she was almost in a bedridden state. She required assistance for for food and going to bathroom, and for maintaining her activities of daily living. Next slide, please. So at presentation, she had tachycardia, blood pressures were slightly on the higher side. She was tachypneic, and she was severely hypoxic. And she had signs of volume overload, like she had pupil edema, and there were crepitations on chest. And she was fully conscious and oriented. Yeah, next slide, please. So in treatment and significant investigation, we found raised infective markers like CRP and procalcitonin, and she had a very high anti-pro-BNP, and her ejection fraction was normal. So we thought her to be having a heart failure with preserved ejection fraction. She had also had azotemia. Hemodialysis was done immediately, and we maintained her on a non-invasive ventilation with her oxygen supplementation. And since there was a recent history of hospitalization and the immunocompromised state, she is a CKD patient and undergoing dialysis, we started her on a empirical broad spectrum antibiotics. We send the cultures. Right. Next slide, please. So in the course, the patient continued to be very dyspneic. Those of you who are not familiar with a non-invasive ventilation, it involves putting a very tight mask in the face, and it is good for short-term use. But if the patient is totally dependent on it, like she was, she could not, tolerate removal of the NIV even for short periods of time, like feeding on or this thing. So it becomes very difficult for the patient. The mouth dries up, the oral care is impaired. Then because of tight fitting mask, you tend to get, you ulcers on the face. So, and she was severely dismissed despite the application of NIV. And so we had no choice. We discussed with the family, and it so happened that in the morning rounds when I came, I gave her getting over from the resident that she was pleading to him that you end my life, na. So then we discussed with the family that the only way forward was to put her on a mechanical ventilation to relieve her, mainly to relieve her from her suffering. So on the day 10th of hospitalization, we put her on a mechanical ventilation, and only after putting her on her ventilation we could do a CT thorax, because she was so dyspneic it was not possible for us to take her to a CT console, and her CT was very bad. I could not show you a CT scan, but it shows diffuse ground glass opacity. There was patchy consolidation in bilateral lung. It is mostly predominantly a post-COVID lung sequel. And we continued her on antibiotics. We modified that. We added antifungal cultures were sent, but which were mostly negative. And to day 17th, we did a tracheostomy because we made several attempts to wean her, which failed because lungs were very stiff. There were poor compliance. And in this, I just want to mention that after we put her on a ventilation, she was conscious. Her daughter Florin was staying outside the state. She came in. She was able to communicate. She was through obviously so gestures. She was fine. But by day 24, her sensorium, she had a confusion. Her sensorium had deteriorated. We thought it would be multifactorial. It was there was a sepsis was there. There was azotemia was there. Also with the CT scan that shows a small frontal bleed. That did not explain as a whole. Nevertheless, she had a frontal bleed. Then she had other complications setting in, like on doing 26, she had upper GI bleed. We had a PRBC transfused. On the 31st day of admission, we had a multidisciplinary team meeting composing of an intensivist, the pulmonologist, and the nephrologist. So this is where, as Madam has said, that now like there's a barriers, regarding predicting the disease trajectory. We all had the differences in this thing. Like the intensivists were feeling that it's there's a futility in care, but eventually the pulmonologists and nephrologists, they say that they were also right in saying that since the patient is not on high vasopressors or not requiring too much support, let us try for some time. So eventually we decided that let us continue treatment till there is a further deterioration. So, but as her condition did not improve any further, on day 43rd, the family decided that to pursue only nursing care. All investigation, antibiotics, dialysis were stopped. And she just continued to be on mechanical ventilation and sedation. And finally, despite everything, she still survived for another 10 days. On day 52, she had expired. Next slide, please. So coming to psychosocial aspect, she had two daughters. She's a very nice, well-caring family. She had two daughters. When we informed the one daughter was a teacher around in 30s. When we informed her about the condition, despite all the COVID, this thing, she flew in for her mother. She was with her. This thing. Both were highly educated. Husband was a businessman. He's a middle class. Though there was affordability, but for last 4 years she was on hemodialysis. There was a chronic ill health. There was a bedridden state, repeated hospitalization. So they had taken a both emotional and financial toll on them. But they had very realistic expectation. They were caring, and only thing they repeatedly told that they did not wish their mother to suffer. And as I told you that one thing that decided us to put on ventilation was that she pleaded us to end her suffering. No, she was having severe breathlessness. Next slide, please. So the medications, among major medication, we use antibiotic, other supportive. From palliative point of view, we use infusion midazolam, we use fentanyl, and yes, we tried to maintain in the minimum dose required. We gave daily sedation, vacations. We titrated the dose to a minimum level. Yeah, next slide, please. So in summary, we had a 65-year-old CKD patient on hemodialysis who had a recent COVID-19 and a COVID sequelae also of the lung. She was admitted with LVF and lower respiratory infection, mechanically ventilated mainly for relief of dyspnea. There was no improvement despite optical medical management, and there were failed weaning attempts. And family wished to continue mechanical ventilation and nursing care till the end. Next slide, please. Yeah. So this is what we think, like, was there was it right to put her on a mechanical ventilation, like this thing, or if not, what were the alternatives? And this is what Madam has described, that this is one major barrier in such cases, unlike in cancer, where it is easy to define the illness, where after stage 4 you can almost predict the life expectancy. Now, at what point we should talk about the futility of care and offer palliative care in such non-cancer setting? And a major difficulty we face is that even among clinicians, as I said in the MBT, there is no consensus that when we should go for a palliative care. Yeah, I think with this I end. Yes. Yeah. Thank you.
Thank you, Dr. Deepan.
Yes.
So we have a 65-year-old man with who has CKD and on hemodialysis. Had COVID, and he has COVID sequelae, and he was mechanically ventilated for this year, and they died on ventilator. So the questions are, was it Rajashri? Can you show the question? Yeah, was the decision to put him on ventilator right? And if not, Dr. Deepam already told that the patient was bleeding to end his life, and because of that, they thought to reduce the suffering, they put him on ventilator. And what would be the time period during which we can talk about the futility of medical care? So, anybody has any comments? Many of you will be working during the period of the COVID patients, and you will be the better person to talk about this. Anybody? Okay, you could have given load of morphine for dyspnea rather than mechanical ventilation. That was from Dr. Sunitha Daniel. Thank you, Dr. Anita. Shilpa says palliative care decision should be taken early before mechanical ventilation. Not sure
Sir,
how this applies to people who deteriorate unexpectedly. Okay.
So should I add something, sir? Yeah.
Yes, yes.
Yeah. Yeah, we did, the only problem with NIV we face is sometimes, like, if you use it was mentioned earlier that we can use the benzodiazepines or using like morphine. So they all have a amount of respiratory depression. So only fear is that if the patient is so dyspneic, so patient often loses her respiratory drive, they go to hypertension. Most important, sympathetic drive and go into hypotension. And more importantly, there is a fear of losing the respiratory drive. So there's an ethical question: if you give a morphine and the patient suddenly, or fentanyl, if the patient suddenly loses a respiratory drive, it will be more like a euthanasia, So this concern is always there. That's the hesitation of giving such medications on a patient on non-invasive ventilation. Invasive ventilation, the things become easy. We anyway sedate the patient. There is no problem because the patient always goes on backup ventilation. Yes, sir.
Yeah, okay. Sunitha, do you want to take that?
I think it's not an easy scenario, as Dr. Deba mentioned. So I was once I saw your case in the morning, I was going through what evidence I can find out among patients on already have got one organ failure. That is, they're on end-stage dialysis a bit. So what will happen if you put them on a ventilator because the lungs have also failed? So whatever is available in the literature is actually, there are conflicting reports. One is that, but definitely in the short term, what the evidence have shown is like one study has shown that those people who have got on end-stage renal failure or dialysis have higher mortality when they go into a mechanical ventilator immediately, or in the like they don't survive the mechanical ventilator as compared to people who's on dialysis but they didn't have to go into ventilator. So that is definitely an evidence. But there's another study which shows that those patients who survive that, suppose they go into ventilator and survive, then the long-term mortality is not different from the others who are still on dialysis but didn't have a ventilator episode. So it's as it's not very clear cut. But actually, generally what they say is that those patients who are on dialysis will not do better if they go on ICU or on a ventilator. So outcome is poor. So that is one of the aspects which you can use in an advanced care planning discussion. So we're not giving the option of ventilator to those patients because we know that the outcome is poor. Now this is one of the way we actually do the COVID advanced care planning also. So I don't know in your states how bad the COVID has become, but in Kerala it has become bad. And one of the things that we're trying to do now is that we've seen that patients who are elderly with comorbidities, who get a bad COVID infection, COVID pneumonia, even if they go on a ventilator, they are not improving. And that is the first wave has shown us that. All the data from all over the world has shown us that there's graphs with ages in them, especially elderly. You can see that their mortality is increasing. And the main problem is COVID is an infection. So we all thought that it's an infection, you can't let people die because of infection. But it is the history has proved us that COVID is not just a simple infection. The cytokine storm is very difficult. So what we are trying to do, at least in Kerala, is that in elderly patients, we are doing this advanced care planning discussions in the community itself. So what we're trying to tell them is that, okay, you've got this, so they're hypoxic in the community. We start the steroids and oxygen at home, and we have this conversation with the family saying that if we are doing the maximum we can with the oxygen at home, but suppose they become more unwell and need higher input / ventilator. Even if you put these patients on a ventilator, they are not getting better. They might actually have a prolonged ventilator stay for 1 month, and then they're going to die of secondary infection. So do you want your family to be cared for at home? At least they are with the family and they can be looked after. And sometimes if the family says that, okay, we'll keep them at home, making them comfortable. So in this scenario, again, if the clinicians felt that ventilator is not going to help the patient, but only with the symptoms, you are justified in giving low dose morphine. Now, the only caveat is that the patient has got renal failure. The morphine causing respiratory depression is actually being proved as not causing because of low dose. I think you must have covered that in the breathlessness talk. You've got lots of evidence which says that low dose morphine doesn't cause respiratory depression. We have given low dose morphine for patients on NIV who has got very, very fast breathing. They've got tachypnea on NIV. We gave low dose morphine and the respiratory rate came down so that we could wean them off NIV. We have been doing that in clinical practice in COPD patients. Renal failure was not there, but definitely when you give low dose morphine, their tachypnea gets better and you wean them off NIV. So that is definitely proven. There's evidence for that. I can give you any number of papers for that. Now, fentanyl doesn't have the same effect. As far as trials go, fentanyl doesn't have the same effects for breathing as morphine. The evidence is not there just for fentanyl oxycodone. Only morphine, the studies have been done. But one option is actually giving very low dose morphine as boluses and seeing whether she responds. So you can just give a subcut dose and see how long that breathlessness will last. You could move her to a place where she's with the family, give low dose morphine and see if that's enough. Or you could just start a fentanyl infusion and see how she goes along with the midazolam. So the idea is, when they become really breathless, it's a terminal situation. If it's a terminal situation and you've got difficult symptom to control, you're justified in starting a medication that will help with the symptom, but actually might shorten things, which is called a principle of double effect. I'm not sure whether you had your medical ethics class, but that will be covered in that. So whatever you start for symptom control in a terminal scenario for a difficult symptom, it might shorten the life of patient, but the intention is not to shorten the life of the patient. The intention is to control the symptoms of the patient, but might end up shortening the life. But what we normally do is we only start a low dose. We titrate depending on the response. You don't give a high dose to the patient. So I think that is the only way I could answer this question. But as we discussed before, we don't know whether it's a, if you're really convinced that it's an end stage episode or a terminal event, then the decisions becomes easier. When we're not convinced, it's not easy. But having said that, patient on a dialysis with having very poor heart also, I think she's an end stage heart failure also. So already two systems are compromised. Are definitely not go and had a very bad COVID pneumonia. Yep. So respiratory is also there. So definitely she's not going to do but on a ventilator. So I don't think, we could, I don't think it's wrong to decide how to keep her comfortable with an infusion.
Thank you, ma'am.
Yeah, Dr. Deepam, as Dr. Sunitha told, we have to differentiate between euthanasia and symptom control. Because in euthanasia, you are giving large dose of maybe a sedative or any other medication as a bolus dose. But to relieve the suffering, we are giving titrated doses of medication, like maybe 1 milligram of morphine, and then wait for another 15 minutes, like that. So that actually will differentiate between euthanasia and symptom control. So even if something occurs, actually the principle of double effect can explain that, and we can't practice medicine without the principle of double effect because many situations anaphylaxis can occur, and do we actually want to produce the death of the patient? No, we want to actually make the patient better, but anaphylaxis happened and the patient died. And this can occur in many of the in medicine, any specialty. So actually, we have to differentiate between these two. And Sunitha talked about two tools. One is STIC and the another one is gold standard framework. So let us ask the surprise question in this patient. Will you be surprised if the patient dies in the next year, month, week, or days? What would be your answer, Dr. Deepak?
No, yes, that was out of question. She was unlikely to, even a month, she was unlikely to survive.
Okay, the next question in this gold standard framework was like general indicators of increasing dependence or deteriorating health. These are generalized deterioration in physical conditions, increasing dependence and need for support for activities of daily living, then multiple unplanned hospital admission, advanced CKD with progressive and complicated symptoms, presence of significant multiple comorbidities, declining performance status, unable to do self-care, so it goes like this. And if you see that if these symptoms are there, then the third step would be whether it is a chronic kidney disease stage 4 or 5 with deterioration with at least 2 of the indicators. The indicators are patient for whom surprise question is applicable. So you already told that this question is applicable. And the repeated unplanned admissions more than three per year. I don't know about that. That was happened. And patient with a poor tolerance of dialysis with change of modality. Patient choosing the no dialysis option or dialysis withdrawal or not opting for dialysis. Then difficult physical or psychological symptoms that have not responded to specific treatment. Then symptomatic renal failure in patients who have chosen not to dialyze, nausea, like symptoms like nausea, vomiting, anorexia, pruritus, reduced functional status, intractable fluid overload. So these are the criteria by which you can actually decide this patient needs palliative care.
Right. Thank you, sir.
And alternatives we Dr. Sunitha already talked about regarding load of nursing. And at what point should we talk about the futility of medical care? So, Sunitha, can we talk on that? When should we talk about the futility of medical care?
I think it's what you've described now, isn't it, Dr. Sunil, about the surprise question and the SPIC tool. Once you use a SPIC prognostic tool, probably that's when you start discussing. So it's always better if you're involving if you want to involve the patient in the discussion, it's always better to start the conversation when he's not ill. When he's in the right frame of mind, not in the first consultation, but in a subsequent consultation when you have a rapport with the patient and the family. It's always better to include the patient also in all this decision making, because they can plan their life accordingly. But it must be done in advance. At the time, probably when you realize that this patient will benefit from palliative care, maybe you could start the consultation. And then in a difficult situation, so if it's all written down, I know we don't have that practice in our country, but advanced directives or not for resuscitation, a document and all, it's very, very useful. And if you have things like that documented and the patient has it with them, even if they come out of hours to the hospital, the doctor who's seeing the patient can make a decision without having to do all these conversations again. And sometimes that happens. The treating team knows the patient very well, but they come out of hours and some other doctor sees the patients and they does everything aggressively, and patient end up having all this being done for. So always better to have a conversation earlier on, maybe at the time when they get the referral.
Yeah, Sunitha, I would like to bring the word advanced care plan here, because many patients with chronic diseases, suddenly they may end up and they may undergo some aggressive treatment which the patient don't want and the family also don't want, but they are forced to do it because they doesn't have any idea on what to do. So I think it is better to have advanced care plan not only for patients who have advanced diseases but also for all of us. So we can actually write what would be our choices if we end up with some diseases, and that will lead on to, and the further aggressive interventions will lead on to poor quality of life. But this actually the advanced care plan or living with actually the Supreme Court of India in 2018 has given a judgment regarding this, and it's a legally valid document. But the problem is that you have to sign it in front of or the first class magistrate has to countersign the document. But even if that happens, if suppose the patient's son or relative says, no doctor, even if he has have an advanced care plan, we don't want to execute that. You continue with whatever is possible. So it is important that the patient and the family have a good discussion on the patient choices, and they have to come to a conclusion. And then this type of things will not happen. A patient has already told that if I need to be ventilated in a situation where I may not, where the doctors think that I may not come out with a reasonable quality of life, then I need not be ventilated. So if that discussion has happened, then aggressive intervention might have, we could have deferred those mechanical ventilators. That's what I think. Anybody else want to contribute? Okay, Dr. Deepam, do you want to ask anything else? You are muted.
No, sir. Thank you, sir. That's a nice perspective. Yes.
I think this is always a difficult decision, but as you go through the ethics and things like these are some tools which can be utilized, gold standard framework and SPIC tool. So you will get an idea, and by practicing, I think we can help the patients to relieve the suffering. Sunitha, shall we end the session?
Yes, Cyril, I think, yeah, nothing to add.
Okay. Yeah.
Thank you.
Okay. Thank you, Sunitha, for having with us today.